I am Dr. Sandeep Suri, working as consultant physician and diabetologist at Holy Health Hospital, Hisar, Haryana. Friends, regarding management of diabetes, whenever we are giving some talk or discussing something related to newer modalities like SGLT2 inhibitors, DPP4 inhibitors, and GLP-1 receptor analogs, and how the whole management protocols, whole guidelines are changing world over. So many times we face certain questions like people want to ask about our thoughts on use of AMPA-LINA combination. When should we use? Whether we should use early? Which type of patient we should use? And what are the effects of this combination on cardiorenal metabolic continuum? And how these things are relevant to Indian settings? So I'm going to explain certain things regarding this AMPA-LINA combination. That is empagliflozin SGLT2 inhibitor and linagliptin is DPP4 inhibitor. So first, I'm going to tell you about cardiovascular benefits of SGLT2 inhibitors and DPP4 inhibitors, a combination therapy. Friends, cardiovascular disease is a leading cause of morbidity and mortality in adults with type 2 diabetes, and the estimated effect is notoriously it is 12 to 15 years earlier than the people with diabetes. If you compare with Caucasian, we develop cardiovascular disease, cardiovascular issues 12 to 15 years earlier than Caucasian or Western population. And the world over, India is notoriously is the capital of young onset cardiovascular related mortality, like young onset myocardial infarction and young onset myocardial infarction related mortality is highest in India. And young onset means less than 40 years. So overall, atherosclerotic cardiovascular disease are twofold higher in diabetic population in comparison to non-diabetic population. But here, young onset patients, they have got fourfold higher risk of cardiovascular event and mortality in comparison to age-matched non-diabetic population. In 2015, we had an era change. We had AMPA-REG outcome trial according to 2008 US FDA mandate. And this trial was done with empagliflozin, 10 milligram and 25 milligram empagliflozin. These patients were having established atherosclerotic cardiovascular disease in 99% of population. And it was around 7020 number of patients they were included in AMPA-REG outcome trial. But the most important highlight of this trial was that when we looked at the primary endpoints, the CV mortality came down by 38%. Definitely, there was 3-point MACE benefit. That was significant 3-point MACE benefit was there. But the CV mortality was 38% reduced in comparison to standard of care arm. And another important thing that came out was all-cause mortality also came down by 33%. So these two findings were very much unique in AMPA-REG outcome trial. Then we had subsequent outcome trials with other SGLT2 inhibitors, canagliflozin with CANVAS program, Declare-TME with dapagliflozin. Then we had meta-analysis. We included phase 3 trial of all these SGLT2 inhibitors, and then we included these three CVOTs. In totality, it was 37 trials they were included in meta-analysis, and more than 30,000 patients were included in these three trials, the three SGLT2 inhibitor trials, CANA, AMPA, and DAPA. And we looked at whether these are the CV death related outcomes or all-cause mortality related outcomes are only given by AMPA-REG outcome trial or by empagliflozin or by any other SGLT2 inhibitor. But to our surprise, they were very much unique only for empagliflozin. So empagliflozin clearly showed that CV death and also all-cause mortality was significantly reduced only by empagliflozin in EMPA-REG outcome trial. Then we had subsequent analysis like how this empagliflozin is doing benefit in CV death. We looked at heart failure related deaths or with or without heart failure. Again, we had benefit. Even without heart failure, we had similar benefit. Sudden cardiac death, again we had benefit. But then we looked at baseline HbA1c value, whether patient having CKD or not, whether patient having heart failure burden or not, whether patient having previous MI or stroke event or not. All these things, all these were consistent showing CV mortality benefit favoring empagliflozin. So clearly we had a molecule which is showing 3-point MACE benefit, which is showing CVD benefit, cardiovascular death benefit, and also showing significant all-cause mortality benefit. Then we looked at heart failure. Among participants with baseline history of heart failure, EMPA associated with numerically lower rate of hospitalization for heart failure by 25%. CV death came down by 29%. And there was no heterogeneity between participants with or without baseline heart failure. Among participants who had initial hospitalization for heart failure was associated with near twofold reduction in risk of subsequent CV death or hospitalization for heart failure. That clearly showed the molecule is showing benefit in prevention for the development of heart failure in diabetic population. And also, we looked at other molecules, SGLT2 inhibitor molecules like DAPA and CANA, they were also showing benefit in heart failure. So CV death, all-cause mortality benefit, and 3-point MACE benefit was all three were concordant with empagliflozin and EMPA-REG outcome trial. We had benefit in 3-point MACE, but no benefit in CV death and all-cause mortality on CANVAS program. We had benefit only with hospitalization for heart failure and CV death as a co-primary endpoint from declaratory trial, but not that much as we have seen from EMPA-REG outcome trial. Heart failure issues are very important. Why it is important? Because 30% patients have got asymptomatic LV dysfunction, and out of this 25% have got diastolic dysfunction, whereas 5% patients have got systolic dysfunction, and they are absolutely asymptomatic without any underlying coronary disease and very shorter duration of diabetes. That means even less than 5-year duration of diabetes. So looking at a prevalence of asymptomatic heart failure, these findings were very much important. Then when we had these overwhelming benefits with from EMPA-REG outcome trial, then we looked at mechanistic studies, how these things are being explained. So we had many hypotheses. Maybe it is due to osmotic diuresis, maybe it is due to natriuresis, maybe it is due to decrease in blood pressure, decrease in arterial stiffness, decrease in vascular resistance, decrease in weight, decrease in uric acid, decrease in oxidative stress. So there are n number of hypotheses which are there for to explain these benefits of from empagliflozin and also from other SGLT2 inhibitors. But no one particular hypothesis could be picked up that this can lead to these much amount of benefits. So not an isolated theory that can be generated. Maybe it is all due to these all pleiotropic effect, these due to all these mechanistic studies, they are showing benefit in all aspects of cardiorenal conundrum. We had other issues like hematocrit also improved. Increased erythropoietin production was there. And that can be seen and that can be labeled. And many researchers, they think that it is 50% of all these benefits are due to hematocrit improvement. But importantly, the decrease in preload and decrease in afterload also contributed very significantly. Then we looked at another aspect. We looked at whether it is due to altered remodeling or altered LV mass index, which may be a culprit or which may show that there can be benefit in CV outcome. We looked at a left ventricular mass index in patients who were not having underlying coronary disease, and we looked at how much the benefit is there in left ventricular mass index. And this was EMPA Heart CardioLink 6 study. It was done in around more than 90 patients, and they showed that within 6 months we were able to have significant decrease in left ventricular mass index. That means these molecules are working even beyond that glycemic effect. They promote reverse cardiac remodeling. They improve myocardial energetics. They improve myocardial filling conditions. They decrease LV wall stress, and that's how they lead to decrease in left ventricular mass index. And they also has got improvement in blood pressure and arterial stiffness. So looking at all these mechanistic studies, they clearly showed that these molecules are extremely essential if we are going to target cardiorenal metabolic conundrum in our patients. And these things are very much important in Indian scenario, and because we are very much prone in comparison to Caucasian population, in comparison to Western population, we develop all these complications of cardiorenal metabolic conundrum in of just within 5 years duration of diabetes, very early. Maybe it is 10 to 15 years earlier than Caucasian population. Another important thing that came out, that once these molecules are being used, they lead to osmotic diuresis, they lead to natriuresis. But what is the difference between these molecules and loop diuretics? They also lead to diuresis, they also lead to natriuresis, they also lead to aqueresis. How they are different than SGLT2 inhibitor class of molecules? Friends, SGLT2 inhibitor class of molecules, they lead to natriuresis, they lead to decrease in plasma volume, but more of interstitial fluid which goes off. So there is much decrease in interstitial fluid in comparison to plasma volume. That's how they lead to better stabilization of sympathetic nervous system. So there is no stimulation of sympathetic nervous system, even if there is decrease in blood pressure up to the tune of 3 to 5 millimeter of mercury systolic, up to the tune of around 2 to 3 millimeter of mercury diastolic blood pressure. Rather, they increase some amount of vagal tone. That's how they are different than loop diuretics, looking hitting at more of interstitial fluid in comparison to plasma volume. These are the molecules which can be used in resistant. Even with loop diuretics, you can definitely use, but the dose of loop diuretics goes down, specifically in resistant heart failure with overloaded condition. We can combine with loop diuretics, but the loop diuretic dose goes off, and if you can go away with loop diuretics as early as possible when you are using SGLT2 inhibitor class of molecules. Looking at heart failure, we had benefit from EMPA-REG outcome trial, from DECLARE-TIMI trial, and from Canvas program. But we had two dedicated heart failure trials with empagliflozin. We had Emperor Reduced trial and Emperor Preserved trial. Both included patients who were having type 2 diabetes or without type 2 diabetes. Both were concordant in their results, irrespective of baseline heart failure, irrespective of baseline ejection fraction, whether there is in preserved ejection fraction beyond 45 or beyond that, or less than 45 or even up to 25, or reduced ejection fraction patient, there was there was significant benefit, relative risk reduction in primary endpoint of CV death or hospitalization for heart failure on top of background therapy. And this background therapy was totally guideline directed. None of the single molecule which has to be given for heart failure was not given in standard of care. The therapy that was there, and you added empagliflozin, and there was around 25% reduction in CV death and hospitalization for heart failure. And the best point is that you had similar benefit whether you are having type 2 diabetes or without type 2 diabetes. So that was an excellent concordance results. They came out with Emperor Reduced and Emperor Preserved trial. And that showed us that these molecules are fourth pillar of heart failure management. Beyond heart failure, left LV ejection fraction boundaries, you can use these molecules. And fourth pillar means you add these molecules along with ARNI, along with beta blockers, and along with MRAs. So they are now taken as a disease modifying agent for management of heart failure. So essential part of management of heart failure. But what about linagliptin? That is being used in combination with empagliflozin, and this fixed dose combination, linagliptin is very important molecule because among gliptin is the widest evidence bandwidth which we had with linagliptin. You have two trials, Carmelina trial and Carolina trial. Carmelina trial included long duration of diabetic patient, cardiorenal sick patient, already established atherosclerotic cardiovascular disease and renal CKD patients, very high risk patient for all cardiorenal events. And Carolina trial had shorter duration of diabetic patients. They were having high risk, but not that much sick like Carmelina trial. And but that was Carolina had active competitor as glimepiride. Friends, in both of these two trials, the molecule linagliptin is CV safe, is heart failure safe, renal safe with negligible amount of hypoglycemia and sustainable decrease in HbA1c value that came from Carmelina and Carolina. That establishes that linagliptin can be used in sicker population having large amount of or cardiorenal sick patients, and also in those patients who have got only risk factor but also shorter duration of diabetes. So, friends, if you combine linagliptin with empagliflozin, it makes a sense of graceful combination. That means you had added advantage of glycemia benefit. You have got added advantage of renal protection and renal safety. You had added advantage of adherence. You have added advantage of increasing compliance. You have added advantage of cardio benefit, cardio protection, and cardio safety. And then this combination is error free. That means weight loss or weight neutral plus there is no hypoglycemia. But as per se, you are using SGLT2 inhibitor and DPP4 inhibitor plus. It is a graceful combination. And the full is the all benefit, all pleiotropic benefit of SGLT2 inhibitor or linagliptin or gliptins. They are just combined and they just exist like hypertension, like blood pressure decrease, weight decrease, and serum uric acid going down. So all these are added advantage when you use this fixed dose combination. Thank you.